Heidi, Heidi's out of town and isn't able to be here, so I'm going to do the intros tonight. And I'm really excited about Tim and Julie being here to present for us tonight. The topic came to me by way of Mary Absalon, who attended a member meeting, and in her evaluation, she suggested this topic. And I think it was like early summer, late spring or early summer, and it was a busy summer for everyone. And so finally, here we are in September, and Tim and Julie are able to present. And I think the timing's really good. And I'm excited to learn more. I'll tell you a little bit about our speakers. Tim is a second degree seeking senior nursing student at St. Kate's, and he's graduating in just over 2 months, and he probably is pretty excited about that, I would think.
Yeah.
His initial degree was a BA in biology from St. Olaf. And he says through a series of experiences, he found that caring and advocating for others as a nurse served a variety of his passions. His interests include healthcare policy research, development, and implementation. And he hopes to explore public health and healthcare policy roles as an RN. And I think that you'll find that there's people in this room tonight, this Zoom room, who share your passions and will be very interested in your topic. And Julie Sabo is an assistant professor at St. Kate's. She's been there since 2022. Prior to that, she was the APRN specialist at the Minnesota Board of Nursing. And every once in a while, when I get a question from somebody about delegation, I'll run it still by Julie, thinking, I think I've got this right, do I? And she's like, you did a good job. So I'm always grateful to Julie. She's a CNS. Her practice was in cardiovascular critical care. And she worked in California, Colorado, Georgia, and then finally came to the great state of Minnesota. She was the director of practice, education, and research at United Hospital before she was at the Board of Nursing. She's currently the chair of the Minnesota APRN Coalition. Her interests include healthcare policy leadership, healthcare systems, and nursing regulations, and she was integrally involved in establishing APRNs as independent practitioners in 2015. And it's hard to believe it's getting to be that long ago that bill passed. Amen. That was such a great thing. Anyway, so I'm going to let you guys go ahead and take it away, Tim and Julie. And
Okay. I've suddenly lost my video. Can you see me?
No.
Oh,
No.
I've got it all turned on. I just don't know what's wrong. I'm very technologically challenged today. All right. Well, I'll try to share the screen here and show task. Hang on. Okay. Can you see it?
It isn't coming through on my end. It just says that you're starting to screen share.
Okay, let me stop again. Not yet?
No. Still don't
Oh,
see
for
anything.
Pete's sake. Kathy, I think you're the backup.
well, I think Tim, you said you could back up, right?
Yeah, I can. Just
Okay.
1 second.
Sorry,
here.
Tim.
No, it's okay. Oh, hold on. Give me 1 second. I closed that document to exit out of this. We were all prepared. We sent all of the emails to make sure everyone had the presentation, and then here we are. That's okay.
I tried it once more. Is it sharing yet?
No, not yet.
Oh, for Pete's sake.
You don't have
Alright.
anything blocking your camera, do you?
No, nothing has changed. I was just sitting here.
Interesting. Oh, hold on. Now I know what to do.
Looks like we lost Tim, did we?
No, it seems like something's funny with this Zoom. Yeah, we lost Tim. Let me see. I'm gonna camera.
Oh, Tim's in the waiting room. He's coming back.
Oh, there's another app using it.
So sorry about that. Apparently Zoom decided to kick me out when I started sharing. We're gonna try this one more time. Okay, can everyone see that?
Yeah.
Great. Julie, can you see?
Yes, sir.
All right, great. Well, after that, a little bit of a clunky start. Thank you so much for having us this evening to present to you all. Julie and I are both looking forward to sharing with you what we learned this summer. And it was an exciting summer. I actually, to give a little bit of background, this project actually just kind of fell into my lap. I've always been interested in healthcare policy and potentially looking at pursuing a JD MPH degree after I'm done with my RN degree in years to come. But also looking at a DMP in nursing leadership, but I'm not sure exactly what I want to do. But this project came up due to the ending of the public health emergency in May of 2023, and Julie was the faculty advisor. So got to meet Julie in May of this, or actually more so March of this last March, and we started the project this past June. So our project is titled as a law and title strategies used in Minnesota for the unwinding of Medicaid and CMS post-public health emergency in July of 2023. So like I said, my name is Tim, or Timothy is my full name. Looks more professional with my headshot, so I thought I'd include my full name. But Julie and I worked together on this project. The project was sponsored by St. Catherine University Summer Scholars Program. Every summer, St. Kate sponsors a Summer Scholars Program where different students can do a research project in multiple different disciplines, or they can do research projects in their specific discipline, but then there is multidisciplinary meetings where we come together and talk about research methods and how to develop projects and how to develop elevator speeches and things like that. So overall, a great learning opportunity this summer. The project was funded by Mary T. Absalon Endowed Fund for Health Policy Research for Nurses. And Mary is a St. Catherine University alumni as well. And it sounds like you all got to meet Mary when she presented to you. So I'm very thankful to Mary for making this project possible this summer. Her fund allowed for us to be able to be paid for this and for the project to be funded and be sponsored by St. Kate's as well. Julie, did you want to offer anything about yourself on this slide?
No, I think Kathy covered it pretty well.
Great. Okay, so as you all know, there is this thing that is called COVID that happened in January of 2020 and changed the world of nursing and healthcare and the world, quite frankly, forever. As a result, we entered the public health emergency. It was declared in January of 2020. It allowed for the health or the HHS secretary to waive or modify certain Medicaid CHIP requirements. And essentially what occurred is that Medicaid was provided with specific funding that allowed for continuous enrollment for enrollees in exchange for enhanced federal funding. And so enrollees who, so I'm sure you're all aware of how Medicaid works, but before the public health emergency, you had to re-enroll every year to determine your eligibility to remain on Medicaid as a Medicaid participant. So that involves sending in paperwork about your how much money you make every year, about your assets and things like that, and the different life accommodations that you might have. During the public health emergency, that was waived. And so then enrollees didn't have to renew every year. They remained enrolled and remained on their insurance without additional paperwork needed. This was called the consolidated approach, or I'm sorry. And then in May of 2023, the public health emergency was scheduled to end. And so then in March 31st of 2023, the Consolidated Appropriations Act delinked the enrollment or the continuous enrollment from Medicaid, basically meaning that the HHS secretary, the federal secretary, delinked the continuous enrollment, and that caused for all of the enrollees who had been able to be on Medicaid without renewal every year during the public health emergency, or the PHE, they had to redetermine their eligibility. So that's across the entire United States. So we're talking millions and millions of enrollees who have not had to redetermine their eligibility for almost over 3 years.
No.
So the potential impact of this, we utilized a resource called the Kaiser Family Foundation. And the Kaiser Family Foundation essentially has established different factors and different guidelines that determine how well a state is going to handle the unwinding process of Medicaid, or and another word for the unwinding process would be the redetermination of eligibility for participants in Medicaid. And so the Kaiser Family Foundation estimated 8 to 24 million disenrolled in US by May of 2024. The HHS had estimated 15 million, but in reality, disenrollments will vary by state by state, based on policy choices and an administrative infrastructure. So essentially, the implementation of this renewal period and of the unwinding was mandated by state. So every state needed to work with CMS to redetermine their citizens' eligibility for Medicaid. And so if we talk about Minnesota specifically in those statistics, that would be 1.5 million. What we discovered this summer would be that 1.5 million Minnesotan residents are currently enrolled, and there's been a 25% increase in Minnesota Medicaid enrollees since the beginning of the PHE. So that's quite a lot of individuals who enrolled in Medicaid during the PHE due to losing their jobs or losing their paycheck due to the different layoffs that were occurring both in healthcare and on multiple other levels of infrastructure. So that's a lot of people who rely on their insurance to get medication, to see healthcare providers, to go to regular appointments for mental health care. And so this could turn into a catastrophic event, not only for the participants or the enrollees, but then for the payers themselves, as it would snowball, because payers are providing the funding, or taxpayers are providing the funding for Medicaid, but then Medicaid is losing quite a few individuals, which then that funding was also refunding clinics and hospitals for different patient stays. So if we talk about the public's awareness of the unwinding, 65% enrollees were unaware as of July of 2023. Nearly half of the enrollees have not had to go through the renewal process because they either enrolled during the PHE or right at the beginning of it. 33% of enrollees have not updated their contact information with the DHS and with Medicaid, and 33% have had a change in income and status. So that means that if you've not updated your income or your status, you could fall off of Medicaid because they can't determine if you are eligible for Medicaid anymore. Additionally, 33% have not updated their contact information. Medicaid's primary source of communicating with participants is by mail. So if participants have moved or have lost their home due to circumstances related to the public health or related to COVID, or have changed their contact information, their phone numbers have changed, whatever it might be, Minnesota's DHS does not have any way of reaching those individuals and letting them know these changes are occurring. Talking from a personal experience, I actually utilize Medicaid as a student because I'm not holding a very high, my job just doesn't give me a lot of hours, and I can't work a lot of hours due to being in school. And I've only received mail information about Medicaid from the DHS. And so individuals who don't have a mailing address will not know about the changes occurring and might go to an appointment or go to a pharmacy and would be charged with the costs of their medications and their care without being aware that their Medicaid has expired. So then what we did this summer, how we developed our project, we wanted to understand what strategies were being implemented by different both state agencies and private agencies across the state of Minnesota. So we contacted 15 facilities or agencies requesting an interview and or information from them regarding their strategies of implementing the unwinding. We created a standardized 8-question interview tool that we used in each interview of individuals from these different agencies. And then we were able to interview 8 policy or healthcare personnel from state agencies, clinics, and facilities across Minnesota. So that included personnel on the county level, that included personnel at the DHS level. We were able to, I butcher his last name every single time, so I'm not going to try, but his first name is Josh, but he's the executive project leader for the unwinding and the renewal. He works with it for the DHS and works closely with the governor's office with the implementation of the unwinding. And so we are able to get a very close view of what the state is doing in the process of the unwinding. And then we are able to interview frontline workers at hospitals and at clinics, at both public and private clinics. And we were able to interview individuals at the hospital level, such as social workers, RNs, leadership, just to hear about what they are doing as well. And then I mentioned as well, county government workers, we were able to interview as well. Additionally, we reviewed and utilized Minnesota Department of Human Services dashboard. So the DHS created this dashboard, which essentially gives statistical data regarding the unwinding process and what Minnesota is doing and how they're doing regarding how many individuals have been disenrolled and how many individuals are maintaining their Medicaid. And so we'll look at this more closely in a few slides because we have a more updated version. But as you can see, on June 6, 2023, the top line there, 72,850 individuals were due for renewal. 10,418 enrollees were auto-renewed, and then 72,001 enrollees with coverage was extended, and then 1,357 enrollees with coverage was closed, so they lost their Medicaid coverage. And so the dashboard gives us in a way a month-by-month idea of what's going on from the DHS's perspective. We also reviewed Minnesota state agency and county websites for information that was publicly available. We also analyzed publicly available data from news publications and current literature. And then we also reviewed national, state, and nonprofit, nonpartisan health policy. So we looked at CMS, we looked at the DHS, we looked at county level data, and we looked at literature that is currently available both on both regarding an international perspective and a state perspective. So then what we found, the results, I mentioned the Kaiser Family Foundation, they have 9 key metrics that determine if a state is going to essentially handle or be successful in their unwinding process with the different processes that they've implemented. And so the 9 key metrics to support coverage include renewal policies, system capacity measures, and this is talking about a state-by-state perspective, eligibility policies, or those are the 3 major sections of those 9 key metrics. So Minnesota meets 6 of the 9 key metrics. The 2 essentially that we do not meet is that we're not performing renewals on an ex parte basis. An ex parte essentially means that we aren't, so an individual, for example, who might have a disability, like someone who's blind. In some states, if they're doing it on an ex parte basis, or if they're not doing it on an ex parte basis, that would mean that an individual with a pre-qualified disability would automatically be re-enrolled. Here in Minnesota, individuals who might have a predetermined or qualified disability will still be determined or considered whether they're eligible or not. So that's essentially like ex parte essentially means like if you're giving exceptions to individuals or not. And then the other is that we did not advance, here I want to get the specific language down, I'm looking at my notes here, but we did not advance 12-month continuous eligibility for children. And there's 3 different sections here highlighted, but essentially the ex parte and the follows up with enrollees who need to take action to maintain coverage are essentially grouped under the same thing. So that's why we're saying, or I'm sorry, I didn't mention the last one. I messed that up. I'm misreading my notes. Apologies, we're backing up a little bit. The third of the 3 that we are not meeting is that we are not following up with enrollees who need to take action to maintain coverage. So if an individual, for example, if the DHS reaches out to that individual and they don't respond, the state is not following up with that individual, essentially. So moving on to the next slide here. Okay, so renewal policies. So this is one of the sections, and this is just, I'm going to be talking a little bit more about these different categories of the Kaiser Family Foundation in more detail here. But in terms of what Minnesota is doing regarding renewal policies, the state is taking 12 to 14 months to complete Medicaid renewals. So the turnaround time is taking a while. The state is following up on return mail, with return mail. So essentially, if an individual turns in their documentation for redetermination of eligibility, the state is following up on the returned mail, and then additionally, if a mail is returned, if the state gets a return address as if their address has changed, they'll utilize an additional form of communication to reach out to them if that is updated. And then the state is following up with enrollees who haven't responded to renewal requests before ending coverage. So they'll try to send something out to that individual one more time. In terms of, and then also what we found is that there's no uniform method to follow up with individuals who do not respond. So the state hasn't developed, like if the individual doesn't respond by mail, then we'll reach out to them by phone. Or if the individual doesn't reach out by mail, we'll look at their past addresses. So there's not really a consistent method that's been established. And this data was developed in July of 23. It's now September. And so we don't really know what Minnesota is doing now or how long it's taking them to complete Medicaid renewals, but this was up to date as of July of 23. In terms of eligibility policies, the state has expanded Medicaid. And then the state, Minnesota has extended postpartum coverage to 12 months. And then Minnesota has also extended 12-month continuous eligibility for children in Medicaid and CHIP. And then in terms of Minnesota guiding principles, moving on then, so that was the Kaiser Family Foundation information. And then moving on, we also reviewed the Minnesota guiding principles that they're using in the implementation of the unwinding process. And these principles have to do with, they are maintaining coverage for all eligible enrollees without interruptions, that the state will comply with evolving federal guidance, and that the state will minimize the burden on the workforce to aid timely processing of the renewals. Because we know from what's going on, I mean, we already saw the impact of COVID on the workforce in nursing. But now on the state level and even on the county level, and now eventually on the healthcare agencies level, there will be an additional stress put on the workforce due to how many individuals need to be re-enrolled, how many individuals need to update their information, how many individuals need to maintain their insurance. So then Minnesota's actions, these are what we found Minnesota is doing. They're using an incident command project structure to implement the unwinding of and this is the DHS, the unwinding of the public health emergency. They hired or contracted Deloitte to project manage for this unwinding. They've increased their workload and their staff. They've tried to develop staffing readiness for this project in terms of developing different tools for their staff, additional staff that can answer phone calls, additional staff who can process paperwork. And then in terms of a private sector, the healthcare sector, different resources have been developed as well. For example, electronic health record prompts have been developed in Epic. So let's say a patient comes into HCMC, the DHS has been working with different hospitals and their charting systems or electronic health record systems to determine when their insurance is, when they need to redetermine their eligibility. And if a patient's redetermination period is coming up, there'll be a trigger in that. As you can see, there's an image on the slide that kind of conveys that, but it will trigger a note on the chart, and it will prompt the nurse or the individual checking them in that they need to renew their insurance. And then there will be opportunity for the patient to renew their insurance right there, depending on the clinic. So HCMC was a clinic or a system that had this, and Regions was a system that had this as well. There's communication toolkits on the DHS website, and that's available depending on which clinics and hospitals have those toolkits. Those toolkits and the resources are multilingual. They're multilingual, and so individuals who don't speak English can utilize them to understand the unwinding process. And then again, the DHS Unwinding Dashboard is a publicly available resource that individuals can use to determine current statistics, but also to determine when the renewal period is, etc. And then continuing with Minnesota actions, a bill was signed in March 30th of 2023. And essentially it addresses the requirements and provides funding for eligibility redetermination to each state. So for the state of Minnesota, 58.6 million was approved for 2024 to 2025, and then 10.3 million to the Healthcare Access Fund was also provided by the federal government, which then totaled to amount of $68.8 million given to the state of Minnesota for the unwinding process. Something we'll talk about in a moment here is the funding was distributed then to counties for unwinding implementation, because Minnesota and the DHS is taking a county-led approach to implement the unwinding, because their thoughts are that each county is more aware of their demographics than the DHS does across the board. So then continuing with Minnesota actions, extensions were given for the first 2 months of the unwinding period. So the unwinding period officially started in June, but enrollees due for re-enrollment in June, they saw, because of how concerning the statistics were, enrollees who were due in June for re-enrollment were then given an extension until July 1st. Enrollees due for re-enrollment in July were then given an extension until August 1st. DHS has given similar extensions to enrollees all the way out through January of 2024. So that would just carry on. So individuals who were due to renew on August 1st were then pushed to September 1st, etc. So I am going to hand it over to Julie from here.
Yeah. So the other things that Minnesota is doing is partnering with public health clinics and payers. And so the green picture is from the Minnesota Council of Health Plans. So that includes, Blue Cross, Blue Shield, Health Partners, different payers. And they are working to keep Minnesotans covered also. And the yellow one is an example from a public health clinic on their website that we found. So they are reaching out to everyone that they can. Next slide, please. This was the timeline for Minnesota, that medical assistance renewals would begin, or preparation for it would begin in April, with the renewals starting in July. Now, you may have read some articles in the news that have changed that, and I'll get to that in a little while. But the goal was by June of 24 that everyone would be on their back to their annual renewal cycle. So it would take, a full year to get everyone who was on Medicaid re-examined for eligibility and re-enrolled or disenrolled as appropriate. Next slide, please. So as Tim said, it's really a county-wide led approach. And I'm not sure if that's because there's some kind of structure in Minnesota that counties do this at the county level versus the state level. I don't fully understand that. But we know that the legislature appropriated a tremendous amount of money, $68 million, and that funding was then distributed to counties to implement the unwinding. As we talked with different counties, we found that there was no follow-up from DHS to the counties. As there's not a standardized data collection from counties on how they're doing, and there's no real standardization across counties, across clinics, across facilities, or really anywhere. Then we decided the picture of the state depicts different shades of numbers of individuals in those counties that are Medicaid recipients. So the darker the color, the more participants in Medicaid. And we decided to look at the counties that had greater than 10,000 enrollees. And we tried to contact different counties, public health administrations. And then we looked at their websites to see what kind of information did they have on it. Next slide, please. And you can see this is a graph of the different counties. We've got Beltrami, Polk, Clay. I can't really read all of them, but the highest counties are St. Louis County, Olmsted, and Stearns County. And those are the counties that have the more urban areas in them: Duluth, Rochester, and St. Cloud. But there's a number of people, say, in Crow Wing, in Candy Ojai, a variety. These are counties that have greater than 10,000 enrollees in Medicaid. And we only found 3 of these counties that had information on the website stating, Medicaid, you have to become re-enrolled, and here's how you do it. Here's who you can contact. Some counties just mimicked what was on the DHS website. So that was a little surprising to us. When we contacted the different individuals at facilities and the counties, we had these standard interview questions, and we would ask, give us a high-level overview of what's being done in your county, what's going well, what is challenging, how is DHS assisting you, have you increased resources, as in personnel, overtime, or even in IT. Next slide. And what we found is that site-specific strategies, and this is mostly at the clinic level or the public health clinic level. They have MNORN navigators who are on site, and they are multilingual. They are taking some sites are taking a proactive approach with clients, meaning that they're looking ahead and seeing who's coming in, working with those individuals. Have they gotten information? Do they need help getting re-enrolled? They have on-site eligibility workers. They're shifting processes. I think it's very fluid at this point to try to meet the growing need. And certainly some sites have got overtime in clinics and agencies. As Tim mentioned, some have flags in the electronic medical record that says this patient's Medicaid has run out, or they were due to renew at this time. And they're also running reports on current patients and updates. Surprisingly, they aren't getting reports from DHS either. Again, that's a place where they're not really sharing. Next slide, please. As we talked to different people, it was so nice that people took the time out. When we spoke with Josh Skurjamaki at the state level, he's the buck stops with him. He really didn't want us to talk with anybody in DHS because he said when they're talking to you, they're not working on the job of unwinding. So it was really generous of people to take their time. And what we found, some of the themes, is that there seems to be a fragmented approach and that it's a trickle-down effect from DHS to the counties, to organizations and enrollees. There's inconsistent communication between state and organizations, whereas I think that they are having ongoing, if it's not weekly, monthly phone calls between public health officials and the DHS, but it's not a consistent approach. We did speak to some frontline workers, a case manager in the ED at Hennepin County, and it's very unclear to frontline workers. They have a very fuzzy idea of what's happening, and it may or may not be factual information. It's more that they're getting information through the rumor mill or word of mouth. There's no consistent method for data collection or sharing. We've got the Minnesota dashboard, the DHS dashboard, but there's not a lot of consistency in sharing between clinics, hospitals, the county level, and DHS. The communication methods that we found between some of the clinics or the counties and facilities are pretty much the same. Some people are more sophisticated using the EHR, but they all seem to have some MNORN navigators, multilingual workers, enrollee assistants. So that's some consistency. When we asked different people about what's going well, they did say that this was building some relationships between agencies, probably because they're all kind of in the same boat. I did ask one person, I said, it sounds like there's some panic. And I would say that when we spoke to people in June, they were definitely feeling some high anxiety. I don't know that they went as far as to say as it was panic, but it was high anxiety. Next slide, please. What we found, hang on my slides, that there seems to be some discrepancy between urban areas and rural areas. And I'll give an example of St. Louis County next. But the urban areas seem to have more resources. There's just more people. There's more clinics, there's more facilities, so they have more resources, and they certainly have easier access to DHS simply by being in the same area, at least in the Twin Cities. Residents of rural areas may have greater risk of disenrollment due to the disparity of those resources. In St. Louis County, I didn't know this, but well, there's two areas in St. Louis County. One is very rural and one is very urban, Duluth and then further north. It's a huge county. And when the public health officials send out their information from Duluth, it has to come down to the Twin Cities post office and then sent back up to wherever it is in northern Minnesota. So imagine how long some of our mail is taking. So it may take extra long for the information to get to the recipient. Then the recipient, if they get it and they understand it and fill it out, then it takes just as long for them to receive it. So there's just a disparity in how our postal system works. It seemed to Tim and I that the bulk of the work was really at the state and the county level. And that makes it a little frightening to those of us who work in healthcare, because we may not feel it in healthcare until the unwinding has progressed further. And so these people, if they don't have Medicaid, those bills won't necessarily be paid. So will there be a financial crisis coming to the clinics or to the facilities. Next slide, please. So when we talked to St. Louis County, I think he was the manager or the director of the public health. He really highlighted the problems between rural and urban. They were using a lot of swag. They were using QR codes, town hall meetings, phone calls, mail, and they didn't seem to be really effective. He was the one that told us about those postal issues that I had no idea about. And he was the fellow that I asked, are you feeling some panic? And as I said, I don't know that he used the word panic, but I would certainly say high anxiety. He in St. Louis County alone, $750 million is spent on Medicaid recipients. And the estimate for St. Louis County was that potentially 27,000 could lose their insurance. Now, in the Washington Post, there was an interesting article back in July that highlighted some of the challenges. And they highlighted two individuals that had the exact problems of the postal issue, not so much the same as Duluth, but one individual had gone in and found out that she had been disenrolled. So she immediately mailed her information in. And when she went to pick up a prescription, she found that she had still been disenrolled, that they hadn't gotten it. So she went down to the county health department, filed her paperwork in person, still had problems with disenrollment. And a lot of these people, once they're disenrolled, they can get back on if they're found to be eligible. But in that interim, they're stuck. And this individual actually used Suboxone for an opioid addiction and was unable to, she was cutting her Suboxone in half. She had gone 2 weeks without it and was beginning to feel the effects of withdrawal. Another woman that was kind of in the same situation, lost paperwork. She sent it in. They said they didn't have it, brought it down. She got her prescriptions filled using some coupons, probably Good RX, but decided not to fill her Symbicort because that's $400. So we have a lot of people who may forego treatment and end up in the ED, end up in hospitals, when that easily could have been taken care of. Next slide, please. So the current data, and I believe this is Minnesota data, right, Tim? Tim had gathered this in August.
It is.
And if
It
you
is
go to the
Minnesota
Kaiser
data.
Family Foundation, you can drill down to the state level. I'm sorry, Tim, did you say yes, it's Minnesota?
Yes, it is Minnesota data. So
at the end of August, 86,000 people had been disenrolled from Medicaid in Minnesota. And 107,000 or almost 108,000 had successfully renewed their Medicaid. 34,000 children, 52, if I round up, 52,000 adults were disenrolled. And that's 38.4 thousand disenrolled in July and 47.8 thousand in August. So you could see these are pretty big numbers that will have significant effect on their particular health and potentially on facilities and clinics. Next slide, please. This is an example of the dashboard. It's not very intuitive. You'll see the top line, it says July of 23, and then it moves up. So you could see, say, in October, there's 108,000 people who are due to be renewed. There's been some auto renewing. They may have auto renewed them because they're over the age of 65 and they're blind, or they have a disability and they're under the age of 65. 36,000 or 23,000, if I'm looking at October, have been manually processed. There were about 6,000 in process, but 55,000 have yet to be resolved. And so you can kind of see what's coming up in November, 126,000, 142,000. And then January is a big number. We'll have 255,000 who are due for renewal. So it's kind of fun to dig into that data a little bit. Next slide. So when we finished this in August, we felt that it was really too early to draw significant conclusions, although I think what we heard from people and the themes are accurate. The process must really be carefully monitored, and that the unwinding is really multifaceted and has inconsistencies. I mean, we know how complex Medicare and Medicaid are, and imagine just trying to figure out now who's really eligible and who's not. The initial estimate of disenrollment was up to 375,000 Minnesotans, and that could really have some negative effect on Minnesota residents, healthcare organizations, and public health agencies. So as nurses, we really need to be an advocate for change, and work with our patients as we see them. Do you have Medicaid? Have you re-enrolled? How can I help you? Get them in touch with social workers or whomever needs to be. And that the legislature likely needs to take more action for equitable unwinding of this. Next slide, please. What was also kind of interesting in June, this was really early on, the U.S. House and Human Services Secretary Xavier Becerra sent a letter to U.S. governors. And in the third sentence, it says, "I am deeply concerned with the number of people unnecessarily losing coverage." And one person stated, at the national level, they are freaking out. And so I think that that probably sums it up pretty clearly. I did search to see if there'd been a more recent letter, because what you'll hear next is a little bit, well, more concerning. Next slide. So September 21st, last week, there was a number, a flurry of articles, New York Times, Washington Post. And in doing some checking at the national level, they found that there were 500,000 individuals who had been disenrolled from Medicaid after computer errors. There was some differences in how interpretations of disenrollment was to occur. And 29 states and DC, and including Minnesota, these states were directed to restore Medicaid to those who had been disenrolled. I don't know if it's all of them or if they're able to tell which have been disenrolled with computer errors. In addition, a significant number of children were denied coverage and will have that coverage restored. But that's just going to cause more rework, redundancies for these clinics that are working so hard, that have been working since June, and the public health officials at a county level that are working to do this. And then we'll have to unwind it again. So how can we be sure that those errors won't happen again? Next slide, please. Some of the implications, as I said, Tim and I kind of struggled to draw significant conclusions from this. We certainly have some general themes. And what we have for implications regarding our clinical scholar work is that it would be beneficial to establish project developments and goals early on. We had a little bit of a challenge because this was really a gelatinous process. We didn't really know what we were doing when we stepped into it. We knew we were heading roughly north, but that's the only direction that we had. So we had to kind of narrow that down. It also requires a significant time commitment. And Tim, as a senior nursing student, was in the midst of his summer internship. So it was really challenging. And the student's commitment needs to be primarily to the project. And that was unrealistic for Tim because his primary commitment is to finishing nursing school. The other thing is that I think we did a good thing by interviewing at the state level at DHS. and down from there. But I think we could have flipped and gone from the DHS to the county level and then to organizations. And we might have been able to piece together what was happening a little bit better. Some of the things that I think have been gained is professional development on both Tim and my part, as far as experience with public health and really fully understanding how complex this is and the challenges just related to how complex Medicaid is in and of itself, but then to try to unwind it from the public health emergency. We were afforded some really valuable and rich networking with the executive director for the Unwinding, who has also an aide to Governor Walz, leadership exposure and scholarly engagement. Next slide, please. We'd just like to give special thanks to Mary T. Absalom for not only her endowment, but she connected with us early on and helped us to form some, or to network. And I think that with her help, we were able to talk with Josh Serjamaki, who is at the top with the DHS. Special thanks to interview participants from Kook Health Partners, St. Louis County, Olmsted County, Regents Hospital, and any that I have missed. And thanks to our university summer scholar program. So we have a number of references for you here, and we would just open it up for questions now.
Well, I can start. This was really fascinating. I appreciate it so much because it is in the news a lot now, and so to have some context and understanding of what it really means. I was thinking about the healthcare legal partnerships, and if some of those clinics, like the Eileen Weber's worked with, if they've done maybe not a better job, but it had a different format to doing the work of unwinding, or making sure that only those who should be unwound are unwound. So just a comment.
Yeah, now that you mention it, she would have been a valuable person to talk to, perhaps. Day late, dollar short.
Way too late.
I'm wondering, oh, sorry.
Oh, go
I'm
ahead.
wondering
No,
if I could comment a little bit. I currently work for Hennepin County and work only with Medicaid recipients, and I just wanted to say a couple things. When we knew that the federal public health emergency was going to, we knew that was eventually going to end. And so I would say that the panic for some of us started about 2 years ago, because they just kept kicking the can down the road. We knew that we were going to get about 60 days, possibly 60 days plus notice of when that was actually going to be like the end, and then when we were going to have to actually start looking at eligibility again. I think the other thing too to think about is Medicaid churn has always been an issue, but it's just on an expanded level. So because we knew that's always been an issue, that we just knew that this was going to be disastrous. Another thing is that there has been some really cool advocacy about what has been done during the COVID pandemic with trying to debureaucratize, I know that's probably not a word, but I'm going to use it. All of the federal stuff, the county stuff, all of that across the country related to this, including in Minnesota. And I think the other thing I wanted to say too is that the implications are huge everywhere, but I think I also just want to say that Medicaid programs too, so waivers, caddy waiver, caddy waivers, elderly waiver, all of that thing. So, even though if a person gets back on Medicaid, they can go back 90 days for payment, there is still that gap of care. If they're in customized living or something like that, then so it's a huge issue. So thank you for taking a look into that.
Yeah, absolutely. I think something that we heard from a lot of the individuals who were working at your level, Christy, was that the panic started earlier than anyone was even aware, and that like the phrase used was they kept just kicking the can down the road, and we're going further and we're further, and we're now even seeing that based on the results and even that current data that was discovered on September 21st of 23. And so it's cool to see, like you said, the advocacy that's coming out of it, and the different awareness that's coming out of it, but then at the same time, how much it actually affects is even beyond like Julie and my comprehension. I wasn't aware of the waivers and all of the other things you were talking about, just because we didn't dig into those specific things with this project. But yeah.
And as a side note, I'm totally gonna look you up so I would love to have a conversation with you at some point. So policy
Yeah,
talk, that kind
absolutely.
of
That'd
thing.
be great.
So thank you.
I would love that. Yeah, thank you.
I'll help make that happen.
Can I just throw in one quick question? I know we're wrapping up here, but I'm just curious, did you get any feeling at all for what is going to happen? All of these people that are disenrolled, do you think most of them will eventually get back on, or some of them just going to be lost forever without coverage? Do we have any idea what's happening with these people that have lost coverage?
So Julie, unless you want to answer this, I feel that we didn't get a good idea from a lot of the agencies that we interviewed, of what would be happening to these individuals. Krista used the term churn, like Medicaid churning has always been a thing. And churning is, I don't know if you're aware of what that term is, but it's essentially where the idea of individuals are on Medicaid and then they can fall off because of eligibility purposes, or they don't renew and then they come back on. And that's always been a process that the state and DHS has been trying to manage and like be better at, not losing or letting those individuals slip through the cracks. But I mean, even before the PHE, that was a struggle. And so a lot of these individuals either will be without insurance and end up like this individual that we highlighted from the Washington Post article, who didn't have her medication for over a month, I believe. And then they are either going out without their medication, or they're paying large amounts of money. I don't know, Julie, do you have a thought about that as well?
You know, I have no idea what's going to happen. I was surprised to read on the 21st that that states were told to re-enroll people. I don't know if that's a surprise to people at the state level, but it just seems, I really have no idea what's going to happen. It's going to be, if it wasn't for people's lives and such at stake, it's fascinating to see, but it's just tragic.
Okay, well, thank you.
Yeah, absolutely.
I'm just going to make a quick comment, because it seems from my perspective at Ramsey County, where I've not really worked in public health until this all kind of started, it was the nurses and the people working directly with clients that were freaked out about this first. So it seems to be like this weird bottom up approach, and trying to get like the top people to listen that this is a really big problem. And a lot of the top down is saying, well, we've got to wait for official stuff. And this was back in March that I was hearing a lot of, we've got to get stuff out to clients, we've got to do this, we've got to do that, from the nurses and like WIC staff. And it was not from the top down.
I remember when my mother was in the nursing home and filling out all kinds of forms for medical assistance, and this was long before COVID happened. And I remember thinking during some of that, I wonder who is helping these folks who don't have family members that would go ahead and fill the forms out and get whatever receipts were needed and all of that. So yeah, I think it really, this must be an administrative nightmare.
Yeah, Jan, it's interesting. I can't remember, and Heather, actually, I can't remember which interview it was, but I remember an individual sharing, because I asked a very specific question about what about the individuals who are the classic, and I think it's because we as nurses see it the most often because we're on the front lines. We see the individuals who can't fill out the forms due to not being able to speak English, or who don't understand the language around Medicaid or Medicare because of their age or because of a diagnosis of dementia or something like that, who might not have a family. And I asked a more specific question regarding like, are the individuals that we expect, are they the ones that are going to be at the highest risk here of individuals falling off of Medicaid and Medicare? And the answer that I got, and this was, I believe it was with a DHS individual, essentially was that, well, yes, that's the case. I mean, we always expect that to happen. But it was, I think for me in that moment, it made me realize how, again, it paints that difference between the nursing perspective and the perspective of like the top down, where the people at the higher levels don't have that same exposure to those patients who, like the sheer volume of patients that just can't do the forms on their own. And so, yeah, it's terrifying for all of those patients that don't have family, don't speak English, are homeless, and or not necessarily homeless, but have mental health issues, and so are not able to maintain a job, substance abuse, etc. There's a difference between, I believe, the perspectives of what is occurring at like the top levels versus the perspectives that nurses are seeing on the ground with their patients.
Another key element that was mentioned, you mentioned the rural versus urban, St. Louis County, where I happen to live, too. That is a key item right now, too, with all the issues that you're talking about here that some of you may need to consider depending on where you're working. There's more research studies going on to look at the difference between rural versus urban opportunities, what medical staff is available and what healthcare facilities are available for these people too. It is a key element that we need to consider with topics like this. So that's good to hear about.
We see Christy has her hand up.
Yeah, I just thought if it would be okay to share some resources for people who can't complete forms and things like that. The things that come to mind just off the top of my head, and if you want me to, I could put them in, like get them to Kathy or something. But I think of in Minnesota, the Senior Linkage Line, the Disability Hub. Also for the Senior Linkage Line, you don't need to be a senior. You can just call. They know they have great things. And I would say also, if they're in the hospital social workers, HCMC will help people get connected to the financial workers if they're inpatient or in one of the clinics. If a patient does have a clinic or go to an FQHC like Kook, there's going to be maybe like a social worker or nurse care coordinator there. And then also for Hennepin, you would call the county, like if it's specific to Medicaid benefits, the county administers them or else the tribal agency. So then you would contact them directly. And in Hennepin County, that would be front door.
Christy, what do you do?
I
You sound very knowledgeable. I think I'm pretty smart. Average. And I can't figure this out.
Well, I worked for Kook before I was a nurse, and then like 20 some years ago. And then I've worked as a nurse care coordinator in lots of capacities. I worked for Hennepin Health, and I will just say here that it gets confusing because part of the Hennepin Soup, that is the Hennepin County owned managed care organization that only has Medicaid and Minnesota Care. So that's their only products. So it's not HCMC, but then I also worked in partnership with HCMC with them. And then now I work for Hennepin County doing Medicaid waiver assessments. So.
Okay. Thank you. You're a wealth of knowledge so far.
Yeah. Thank you, Christy.
And I was just going to say, if anybody has questions, please let me know. And I'm always happy to talk about this stuff or give resources.
So I think we're about at the end of our time. And yeah, I think we could talk about this forever because like part of me says, like, if this has been churning forever, why don't we do it differently? Time for innovation. So
absolutely.
I want to thank Tim and Julie for this wonderful presentation and for the work you did all summer long. It's amazing. So thank you
Thank
so
you for
much.
inviting us.
Yeah,
Yeah,
thanks.
thank you. It was a pleasure to present to you all.
Um,
Thank you.
You'll be getting an evaluation, and then after that, you'll get a certificate of attendance, those of you who are here. And dates to remember for the future, October 19th is our next meeting. And Martha Turner is going to be talking about the process for revisions for the Code of Ethics for Nurses. She's involved in that again this time around, and why it matters to do these revisions. And then on November 16th, Teddy Potter's going to talk about planetary health, calling nurses to co-create the great transition. So we have a couple of two more dynamic presentations coming up this fall. So thank you all for coming. And any last comments from anyone? I think you're getting lots of thank yous in the chat.
Great.
So
We enjoyed it.
Great. And now everyone go pet their dogs and tell them that they were good boys and girls.
Thank you.
Yeah.
Bye-bye.
Thank you all. Have a good night.